Hello everyone, warm greetings to my respected seniors and my dear colleagues. I am Dr. Binhi Desai, practicing ENT and voice surgeon at Swar Voice and Swallowing Clinic, Borivali, Mumbai. I will be presenting a rare and a challenging case of a primary tubercular laryngotracheitis which developed into a stenosis. This was managed with tracheal balloon dilatation under Thrive anesthesia. A 21-year-old young male was referred to my voice and swallowing clinic at Borivali, Mumbai with complaints of cough and hoarseness since 2 months. He was suffering from cough, cold and fever since past 2 months, for which he had taken treatment and had recovered. On examination, his vitals were stable. On auscultation of chest, he had bilateral creps. On performing a flexible laryngostroboscopy, he had inflamed supraglottis, glottis and subglottis. His vocal folds had restricted adduction movements. On performing a FEES, which is fiber optic endoscopic evaluation of swallowing, he had complete aspiration for water. A nasogastric tube was inserted. Routine hematological, radiological and sputum examination were performed. A diagnosis of acute laryngotracheitis with aspiration pneumonia was made. Treatment was started accordingly and the nasogastric tube was removed at 10 days. Over next 1 month, he developed breathlessness, which was so severe that he feared he would die from it. He also developed hoarseness since past 1 month. On examination, his saturation was 92%. He had a biphasic stridor. On doing a flexible laryngoscopy, he had a bilateral scarred vocal folds fixed in paramedian position with a posterior glottic web, grade 1 as per Bogdassarian classification. He was immediately admitted and taken up for anesthesia. He was planned for a diagnostic laryngobronchoscopy under anesthesia. The findings were of a bilateral scarred vocal folds with mobile cricoarytenoid joints with a posterior glottic web. Tracheal mucosa was inflamed and granular up till approximately 7 cm beginning from the level of vocal folds. The lumen was becoming narrower inferiorly. At the inferior end, the lumen was only 3 mm. Only 5 rings above carina were normal. Posterior glottic web was released with the help of cold steel. Specimen was collected and sent along with bronchoalveolar lavage for evaluation. Post-procedure, the patient reported mild improvement in breathlessness due to the release of the posterior glottic web. Histopathology came as inflammatory tissue. Culture sensitivity from the lavage came as Pseudomonas. Gene expert came as trace Mycobacterium tuberculosis. Patient was treated as per the culture reports. At 1 month, a repeat laryngobronchoscopy revealed a healed posterior glottic web with a scarred but a mobile vocal folds. The granular and inflamed mucosa over the trachea had healed with a long stenosis starting from the level of the vocal folds, tapering inferiorly to a pinpoint level with a diameter of just 3 mm. 5 rings above the carina were normal. Virtual bronchoscopy revealed similar findings. The patient was taken up for tracheal balloon dilatation under apneic ventilation using Thrive anesthesia. Thrive stands for transnasal, humidified, rapid insufflation, ventilatory exchange. It is a physiological method of increasing apnea time in difficult airway. Intraoperatively, first dexamethasone was injected into the stenosis. A Mercedes-Benz incision was given with cold steel over the narrowest part of the stenosis. This incision was made to release the scar up till the cartilage could be palpated in 12 o'clock, 4 o'clock and 8 o'clock positions. Tracheal balloon with a length of 40 mm, diameter of 14 mm was inserted, ensuring that the midpoint of the balloon coincided with the maximum narrowing. This was to give maximum radial pressure at it. The pressure was given first time at 8 atmospheric pressure for 15 seconds. This was repeated twice at 9 and 10 atmospheric pressure for 45 seconds each time. Mitomycin at the dose of 2 mg per ml patties were kept for 2 minutes. Patient tolerated the procedure well. He reported 90% improvement in breathlessness. Opinions from chest physician, infectious disease specialist and rheumatologist were taken and all advised investigations were done which came to be normal. Pulmonary function test showed a pure upper airway obstruction. Anti-tubercular treatment was started which the patient tolerated well. At 2 months and 6 months follow-up, the patient had no breathlessness. Diagnostic laryngobronchoscopy revealed a scarred but a mobile vocal folds. The point of maximum narrowing of the stenosis had widened adequately and healed well. The tracheal mucosa was also scarred but had healed well. At 1 year follow-up, the patient had returned to his hometown, performing all his routine activities without any fear. He had a mild breathy but a serviceable voice. To conclude, the diagnosis of primary tubercular laryngotracheitis requires a high level of suspicion. Laryngotracheal stenosis is a life-threatening condition and hence requires urgent treatment. Treatment options are balloon dilatation, stent placement, laser, cryotherapy or surgical resection. Anesthesia is also very challenging in such cases. End goal must be to give a stable airway. Long-term follow-up is necessary. Thank you.